Hello, my name is Nanette Nessel. I'm a board-certified pediatrician and retired geneticist with over 20 years' experience in clinical medicine. I'm here today to talk to you about pharmacogenomics. I'd like to talk a little bit about what it is, how it can be helpful to you and your patients, its ease of use, and its cost effectiveness. Let's start with what pharmacogenomics is. Wiki defines this as the role of the genome in drug response. It states that the technology analyzes the genetic makeup of an individual and how that affects his or her response to drugs. Wiki then goes on to use big words like genetic variation, gene expression, and single nucleotide polymorphisms. Why did I start with a wiki definition? Because that's where your patients are going to start. The NIH defines it as the study of how genes affect a person's response to drugs. This relatively new field combines pharmacology, the science of drugs, and genomics, the study of genes and their functions, to develop safe, effective medications and doses that will be tailored to a person's genetic makeup. For today, let's use this definition, the study of how genes affect a person's response to drugs. It's simple and says the same thing as the other two definitions. Why is this important? Let me start with a couple of scenarios. Say, for example, you have a patient with a chronic illness and you have a medication that you like to use for that particular patient, but in that patient it either doesn't work or the patient is plagued by side effects and you have to stop and change to a different medication, and then a different medication, and then a different medication. For me in pediatrics, that would be attention deficit hyperactivity disorder. I have a particular drug that I'd like to start with because it's effective in most patients and it's relatively free of side effects when dosed appropriately. However, there are patients where it simply doesn't work that way. Either we go up to the maximum dose and they don't have the needed effect, or they're plagued with side effects and we have to stop and change medications because of that. So I'll start with my preferred drug down here and I'll follow the guidelines and I'll go up and up and up gradually until we reach the maximum dose. And if that's still not effective, then I have to change to a new medication and start at the low dose and gradually work up until we see the desired efficacy. Now, if a patient develops side effects, then I have to stop here and go to another drug. In a child, that may cause them to lose an entire year of school, and it can be devastating for them and their families. In the adult world, you see things like PTSD and depression, where you may go through 4 or 5 medications, and your hope is that you can find something effective and relatively free of side effects before they harm themselves or someone else. What about cancer? I think we all have taken care of patients who have cancer, even if we aren't their oncologist. I think this is still important information to know because cancer does affect all of us, either in our practice or in our personal lives. For years now, we've been able to test cancers for certain genetic markers and find the right antineoplastic medication or group of medications that are going to be most effective against that particular tumor. However, now we also have the ability to test the patient and see which of those effective medications are going to give them the least number of side effects. Those are all scenarios. Let me give you an actual case study. In 2009, a 2-year-old boy went into the hospital for routine tonsillectomy for obstructive sleep apnea secondary to tonsillar hypertrophy. He made it through the procedure without any difficulties and was discharged home to his parents. He was prescribed codeine for pain control postoperatively. 2 days later, he presented to the emergency room in respiratory depression and died from respiratory arrest. Why? Well, there was an investigation, and through the investigation it was learned that he was prescribed the correct dose of codeine for his weight and age. It was on the correct dosing schedule, and parents gave it to him as prescribed. So why did he have respiratory depression? Pharmacogenomics testing was done as part of the investigation. It was learned that he had not 1, not 2, but 3 copies of a gene that converts codeine into morphine. He was described as a fast metabolizer, a term that I think has been unfortunate because it implies that he was able to metabolize the codeine faster and get it out of his system, when in fact he metabolized it to morphine at a faster rate and therefore a higher level than what was expected. A couple of years later, 2 4-year-olds underwent the same scenario and also died. So what did we do? Did we start testing all children to see what pain medications could be used for them and which ones couldn't? To find out which children were going to metabolize codeine and morphine more quickly than expected and which ones weren't? No. We villainized codeine. I was working with a lot of pediatricians and ENT physicians when this information first became available. And unfortunately, most of us couldn't get our hands on the actual case report. What I saw were ENT surgeons who felt that this problem was had more to do with the sleep apnea, the obstructive sleep apnea. They felt that because the child went from an obstructive respiratory state to suddenly a non-obstructive respiratory state, that somehow led to pulmonary edema and respiratory arrest. They didn't really talk much about the child being a fast metabolizer. Pediatricians, on the other hand, worried that codeine was simply too powerful a narcotic to be used in preschoolers, so they stopped using it, particularly in postoperative settings. Again, nobody was really talking about this child being a fast metabolizer and what that meant. The FDA came out with a black box warning. The black box label discussed obstructive sleep apnea. It discussed children 4 and under, and it discussed fast metabolizers, but it didn't define what a fast metabolizer was or what the significance of that was. So what we've done is we've stopped using codeine in kids 4 and under. Then, in 2016, a 9-year-old had the same problem. He underwent tonsillectomy, had codeine postoperatively, and died of respiratory arrest. Again, we're still not doing pharmacogenomics testing to see who is at risk for this and who is not. Instead, the American Academy of Peds has advised against use of codeine in all children, everyone 18 and under. My concern is that it's only a matter of time before this happens to someone outside of the pediatric age group. I think from what we've talked about, you can now see why I feel this is important, not only for your patients, but for you as clinicians. It can save lives, it can rescue lifestyle from potential side effects, and it can improve efficacy. Is it easy to use? It's extremely easy. It's not even a blood test, it's a buccal smear. You swab the inside of your client's mouth, you send it off to the lab, you get your report. Is the report easy to read? It's extremely easy to read. It's as easy to read as a traffic signal. The report comes back with medications grouped by drug class. And then within that drug class, they'll be divided up into red, yellow, and green categories. For patients whose lab result results in drugs being in the red category, you may want to consider using a different medication. For those in the green category, you've little to worry about. And for those in the yellow category, those should be used with caution. Here, I'll show you. Is it cost effective? Yes, it is. For starters, the testing is covered by most insurance companies. But the real cost efficacy of pharmacogenomics is in the amount of money saved by not having adverse drug reactions. Adverse drug reactions account for 770,000 hospitalizations in the U.S. every year. For an individual hospital, the cost can be as high as $5.6 million, depending upon the size of the hospital. Across the country, it's roughly $30.1 billion a year. Imagine how we could change medicine in this country if we put that $30.1 billion back into healthcare. Is this leading edge medicine? You bet it is. Is it going to become standard of care? I truly believe so. And I'm not the only one. Pharmacogenomics testing has been widely endorsed by a number of major medical universities. Harvard, Vanderbilt, Northwestern, Baylor, to name a few. Mayo Clinic strongly endorses pharmacogenomics. These and several other groups have collaborated and are starting educational programs for both physicians and for basic science researchers. There are master's programs in pharmacogenomics for the basic researchers. They're starting residency and fellowship programs specifically to teach our young physicians how to look at use of pharmacogenomics in clinical medicine. This is the direction medicine is going, and it's my belief that the longer we wait, the more harm we may be doing to our patients. Nobody wants to be the doctor that's involved in one of those. Have you or a family member been damaged by drug XYZ? Please contact the law offices of Smith & Smith. You could be eligible for compensation. Yet none of us wants to be there with that. What we want is to provide the best medicine possible for our patients, and I truly believe pharmacogenomics can help us do that. So I hope that today I've shown you what pharmacogenomics is and how it can be useful to you and your patients. I hope you can start to see the importance of this as a tool in everyday clinical medicine. It's easy to use, it's cost effective, and it's endorsed by a number of major medical groups. If you are interested, please contact us and we'll tell you how to get started. If you have further questions, please leave them in the comments section.